Hi, my name's Jorid and this is my research proposal of endotracheal securing devices in the ICU and reducing the pressure-related injuries. In intubated patients, there is often more emphasis on making sure the endotracheal tube is secured to the face rather than pressure injuries. Oftentimes in intensive care, we're more concerned about keeping the patient alive hemodynamically, and pressure area care can fall to the side. Ulcers at my current workplace are at a reportable prevalence. Pressure injuries and ulcers are a preventable injury in intensive care. There is high cost to the company, around $20,000 to $30,000 per pressure injury. There is high nursing cost as well, due to time documenting and managing injuries. And of course, the cost to the patient, scarring and a constant reminder of time in ICU. The Braden scale is a summated rating scale used on admission for potential risk for developing pressure injuries. This is documented on admission by nursing staff, then once daily during intensive care stay. A lower Braden scale score indicates a lower level of functioning and therefore a higher level of risk due to pressure injury development. Pressure injury care is a continuing development as medical treatment advances and consumers of health become more multifaceted and with multiple comorbidities. As healthcare providers, there must be ways to improve practice, reduce and minimise the occurrence of preventable pressure injuries. There must be across-the-board diligence when it comes to pressure area care, and critical care nurses are at the front line of assessing, providing and documenting said care. As highlighted by the Australian Commission of Safety and Quality in Healthcare, pressure injuries can occur in any aspect of nursing, but when a patient is deemed to be immobile, their nutritional status is compromised and their skin integrity is compromised, the risk is greater. There is no greater risk than the intensive care patient. To the right of the slide is the graded pressure injury scale. Currently at my workplace, there are two modes to secure endotracheal tubes. Cotton tape, which is bought from the local Officeworks store, is a cost-effective way of securing endotracheal tubes. It's the nurse's preferences in tying, and the hospital policy dictates that no knots are to be used, and when secure on the face, 2 fingers are able to be slid comfortably under the tie. There is also a Hollister Anchorfast brand, usually reserved for long-term intubated patients. This has adhesive pads on the side which secures to patients' cheeks and a slidable oral mouthpiece for ease of movement. It is a bedside nurse's preference to use either modes. As with all airway management, there needs to be 2 registered nurses at all times with securement of devices. So the key research questions that I've identified are intubated intensive care patients, cotton ETT tape, Anchorfast ETT holder, and the outcome is that I would like to minimise or eliminate oral pressure ulcers caused by these mechanical devices. A thorough literature search was conducted and revealed an obvious gap regarding a superior way to secure endotracheal tubes to minimise pressure injuries in the compromised intensive care patient. Papers from Pender and Fraser and Coyer and Stotts focus was the force that was required to pull out or dislodge an ETT from an airway. 4 other studies focused on the knots used in the cotton tape, again for securement and not for pressure injury risk or minimisation. Gardner et al., Black et al., and Astelio et al. Have all identified that more studies need to be conducted to focus on the link between intensive care patients and medical device-related pressure ulcers. Hollister Anchorfast released a study by Miller with their product, which used an intervention of an unnamed hospital unit with tying of the cotton tape to ETTs and comparing it to their product, the Anchorfast Hollister brand. They measured the amount of pressure injuries sustained by both products. This is the only study I found that actually related to my topic. But their small sample size of 16 patients and obvious company bias in an unnamed hospital deemed the study statistically insignificant. Methodology. For this study, I'll be using retrospective and prospective mixed methods observational studies. This is level 2 evidence on the evidence pyramid. I will be using this mixed methodology because of the known high prevalence of pressure ulcers in the intensive care unit. Data collection is ongoing, and the longer time frame will strengthen this study to make it more statistically relevant. Methodology. Riskman data will be collected as all pressure injuries, ulcers over stage 2 are reported via computer software. All ETT-related pressure injuries will be collated. Other data to be collected would be patient's Braden score on admission, the grade of pressure injuries on the mouth, ears, or under the medical device, how often was oral care undertaken, which ETT securement device was used, patient age, and patient admission diagnosis to ICU, and also how long the patient has been intubated. Data will be then collected and analysed. Quantitative data will be taken from a time period from August 2015 to August 2017. Statistical significance will be measured with a p-value of greater than 0.05. Proposed project outline for this research proposal. Which way of securing an endotracheal tube, cotton tape, or Anchorfast reduces the amount of device-related caused pressure ulcers? The objective is to determine a superior way for securing an ETT with the products currently used across Australia intensive care units to minimise or eliminate oral pressure-related injuries. The study centre will be conducted in a large metropolitan hospital. The intervention that will be used will be retrospective and prospective documentation review. Data collection will be collected through patient notes and Riskman data. Data analysis will be undertaken using quantitative methods of analysis of Riskman data reported pressure injuries. Strengths and limitations of this study is that it will be conducted in a single site. Approval pending from hospital research team and Director of Nursing for this research proposal. There is low ethical risk due to anonymity of data collected. Proposed timeline for this research proposal. Pending is done in research approval for this month. The literature review has already been completed. Hospital and ethical improvement will be aimed for the end of the year. Data collection and analysis for the end of next year, and data presentation for November 2017. As I'm using prospective and retrospective data, last year's data and this year's data will be included. So what are the outcome aims for this research proposal? Obviously, we're trying to reduce the amount of oral pressure-related injuries in intensive care. Finding a superior product, saving money and time for nursing staff due to decreased documentation, workload, and pressure area care, enhancing patient safety and comfort, and applying evidence-based practice to our practice. Thank you for taking the time to listen to my research proposal. Please feel free to leave comments or questions on the feedback forum.